Hello and welcome MVMA members. Thank you for joining today's Lunch and Learn webinar, Multimodal Management of Osteoarthritis with Dr. Christopher Lewis. I'm Nicole Cass, CE Program Manager for the MVMA, and my role is to moderate the Q&A. A quick review to help you navigate the webinar functions. Please note that depending on the type of device you are using, you do have the opportunity to minimize the various boxes, making the slides larger. And note that the Q&A icon is where you should submit your questions at any point during the session. If you're not able to find those icons, hover over your cursor at the bottom of your screen and it should appear for you. I'm delighted to welcome today's speaker, Dr. Christopher Lewis. Dr. Lewis attended Kansas State University for undergraduate studies in veterinary school. After graduation, he moved to Las Vegas, Nevada, and practiced in small animal clinics for over 10 years. Later, Dr. Lewis returned to school for a Master's of Public Health, again at Kansas State University. Upon completion of the MPH program, he moved to Washington, D.C. to work as a veterinary consultant for biosurveillance, biosafety, and biosecurity capabilities. Since 2017, he has worked as a technical services veterinarian with Vetoquinol. In 2019, Dr. Lewis became a diplomat of the American College of Veterinary Preventive Medicine, which promotes preventive medicine and public health in the veterinary community. Dr. Lewis is also a member of AVMA, the Kansas City Veterinary Medical Association, the American Association of Feline Practitioners, the American Association of Veterinary Parasitologists, and the International Veterinary Academy of Pain Management. Please welcome Dr. Lewis.
Thank you, Nicole. I want to thank everyone for joining us today. And I guess I'll do a little explanation. I'm actually based in Kansas City, but I am actually at a clinic in Tulsa that specializes in acupuncture and physical therapy. And so I am in one of their procedure rooms while they are having their office meeting. So I want to thank y'all for joining me today. And we'll spend some time today talking about multimodal management of osteoarthritis. And Nicole and I were chatting just a bit ago. This is a topic that I really enjoy, and I'm in a great situation where I'm able to, attend clinics like this and go to a lot of lectures. So I get to take in a lot of information from various veterinarians and get to try to compile it all. But I actually spoke at a conference on this for about 3 hours. So we're going to try to get this into 45 minutes. So obviously we're not going to be able to cover everything. And some things that are kind of well covered, I'll probably kind of glance over a little bit. And then as I start going, you will probably notice my my talking go much faster. So please bear with me. And not all of this is going to be new. There's going to be some review here, but hopefully we'll kind of give you some ideas. And if you're already doing multimodal management, excellent. That's the way we want to do it. But maybe we'll have some other ideas or other things to consider. So we'll leave some time at the end for some Q&A. But on that note, we will go ahead and get started. I think. There we go. Okay. So we're just going to do a quick overview on osteoarthritis. There's not going to be any tests on this or anything like that. It's just to make sure that we're all in the same, same wavelength when it comes to discussing osteoarthritis. So it is a progressive degenerative disease of the synovial joints. And that's important to remember. It's progressive and it's degenerative. So we're not going to stop it. We just want to try to slow progression. And we want to do our best to keep normal structure, normal function as long as possible. So that's what a lot of these modalities are going to try to do. But we do get inflammation, destruction of cartilage, bone remodeling, loss of joint space, and pain. And this is not an uncommon hip when we see hip dysplasia with a lot of these changes already there. That's not the worst we see by any means, but that's what we often think of when we think of OA. So we just want to, again, keep in mind that it's progressive and it's degenerative, and those are what we want to slow the progression. And really want to just kind of help you remember that it's out there, and it is something that there's been a few studies looking at the prevalence of osteoarthritis in pets, and there was a study done by Dr. Millis at the University of Tennessee. There are dogs that were undergoing dental procedures while they're anesthetized. They did X-rays, and they found that 68% of these dogs had at least one joint with radiographic changes, and then multiple joints affected in a lot of these animals. But one thing that was noticeable was that of those 14 of these animals that had OA, 10 of those 14, the pet owners didn't say they had any clinical signs. So these dogs had osteoarthritis present on x-ray, but the owner didn't notice it. So that's unfortunately what we often see is it's there, but the owner may not be picking up on that. So we have to do our best to try to help tease out that information, and we'll talk about a little bit about that as we go. As you heard in my intro, I'm a member of the AAFP, so cats are kind of, kind of our cat advocate. So it is an issue in cats. There was a retrospective study looking at X-rays. I believe this was at Minnesota, I believe, and they were looking at cats that had X-rays for other reasons, and they found that 90% of cats over 12 years old had some level of radiographic change associated with arthritis, but only 4 of those medical records actually mentioned DJD or arthritis. So it is an underdiagnosed problem in cats, and we'll talk about that a little bit more as well. Really just want to help you understand that it is there, and we may not be noticing it because the pet owners may not be bringing that up to us. So that's going to be important when we're getting our history, when we're doing our physical exam in the room, see if we can pick up on those things and really try to help advocate for these patients. Not only because we want to do good quality of care, but we also want to, well, it could be a potential good revenue stream for us. So at Michigan State University, this was a while ago, 2009, but they looked at the median cost of care to manage a patient with arthritis, and they found is about $1,600, over $1,600, and that's with different modalities. So that might be pain medication, that might be supplements, that might be underwater treadmill, laser therapy. And there's a lot of things that can be done now. And so it is something that it can be a definite revenue stream. And then we look at the 75th percentile, over $3,000 were spent. And so not every pet owner is going to be able to do that, obviously, but those that are willing and able, you will see that they're willing to spend the money to keep their pets happy and comfortable. And just my experience over the last 2 days at this clinic, I mean, there's pets that have been coming here for years, and happy to come in once a month or every other month or weekly when things flare up. And so we do have a lot of pet owners that are willing to do it. So we don't always want to make the decision for them that, oh, they probably won't want to do these other things. We just want to, again, keep an open mind on that. And the causes, I kind of break it down into 2 common causes, primary osteoarthritis and secondary osteoarthritis. So primary would be age-related changes. That'd be that wear and tear, idiopathic change. That's more commonly seen in cats and people. Those are what we often think of. And it's just, it's age-related. With dogs, though, usually it's secondary osteoarthritis. So the 2 I think about are normal anatomy and abnormal forces, or abnormal anatomy and normal forces. So if you have a dog like this, that's a tick. And so there's going to have, extra weight on those normal joints. So that animal is going to be predisposed to developing osteoarthritis. Or if we have an animal that has a torn cruciate on the right knee, they might start putting more weight on, they're going to shift more weight to the left and maybe more towards the front. So we might start have more changes on the left side, and maybe that left elbow, that left shoulder becomes more of a problem. And then when you throw in abnormal anatomy with normal forces, you can have a perfectly weight animal. And if we have a congenital issue, if we get a ruptured ligament, if we have a traumatic injury that affects that joint, then that animal is going to be predisposed to arthritis because things are no longer moving normally. And then if you throw in abnormal forces, like all this weight on abnormal anatomy, then it just makes things that much worse and that much faster to develop and that much faster to progress. We don't want to forget about autoimmune or infectious causes, not as common in veterinary medicine, but those are things we want to keep in mind. And not to say that dogs don't get primary OA, not to say that cats don't get secondary OA, but for the most part, we're going to see those kind of separated there. And then real brief review of anatomy, because no one wants to deal with this over lunch, but just kind of sets the tone for when we're talking about some of our therapeutic options. So the environment in this joint should be a sterile environment, so there shouldn't be any bacteria, any cartilage, any collagen, anything floating around in there. It should be avascular, so there's no blood supply going into this joint, which can make it slow to repair. And there's also no nerve endings directly into the joint. So if we are getting pain, it's often from the soft tissue structures around, or if we start getting erosion through the cartilage, maybe we're starting to get some bone pain. So that does make it sometimes tough to diagnose, but it also makes slowing difficult because when you don't get blood supply directly, it can make our healing much slower. If fluid builds up in there, there's no vascular drainage or there's no lymphatic drainage there, so it makes it a little bit harder to get that out of the way. Although that's not as common in dogs as in people, but we will definitely see that. And just kind of briefly touched on, if there's something in the joint because it's supposed to be a sterile environment, then we will often get an excessive immune or inflammatory response. So as few as 12 colony-forming units of bacteria could potentially cause sepsis within the joint. So if we're doing joint taps, if we're doing joint injections, things like that, then we definitely want to be very careful. But even things like damaged collagen, I mentioned that, and we'll go into that a little bit more detail shortly. That's not supposed to be there. It's a foreign object. The body reacts to that. And then once we get some inflammatory mediators in there, that can cause a more dramatic cascade and just kind of increase that inflammation and kind of snowballs from there. I mentioned that lack of lymphatics means lack of drainage. It still drains, but it just takes quite some time. And when we're thinking about the articular cartilage, we want to kind of keep in mind, and these are things we probably know from years ago but forgot, but when we're thinking about the cartilage, it's 80% water. So we need to keep these animals hydrated. Dehydration alone can cause problems to get worse, but we have about 20% of this cartilage is made up of type 2 collagen and our proteoglycan matrix. So those proteoglycans are glycosaminoglycans, which are made up of chondroitin and keratin. And these are things that we often think about when we're thinking about supplemental support for patients to try to help keep that cartilage in good health. And so that'll come up a little bit more when we talk about our treatment. So again, these are things that we want to kind of keep in mind. And type 2 collagen is something that we'll talk about a little bit more very shortly. We all kind of know what the predisposing factors are, but again, we want to kind of, again, make sure we're all on the same page. And something to kind of keep in mind is when we're thinking about the most commonly diagnosed orthopedic conditions, we all kind of have, probably rattle these off pretty easily. Although number one, we don't always think about, although it makes sense, osteoarthritis, that's that umbrella. It kind of covers so many of these conditions, but osteoarthritis would be one. But then we think about our cruciate rupture, hip dysplasia, elbow dysplasia, and luxating patella. Don't forget those little guys, the little dogs that barely touch the ground. They're usually in the owner's arms or on the couch or in their bag. They still have problems and they still have pain. They just may not show it as much because they don't do as much. Sad to say, but we want to keep them in mind as well. But these are the real big things that come into play as those predisposing factors. So body condition, again, as we discussed, overweight, more stress on those joints, no matter what your conformation is. Any type of traumatic injury that involves a joint or causes, some type of immobilization for a long period of time, that changes the dynamics of those joints. Definitely our occupation, those working dogs, dogs that fly ball, dogs that are agility dogs. Anytime you have excessive, motion and force, then you have a greater chance of an injury. And then we have that breed predisposition. If you, depending on what we see most commonly, it's like, okay, labs with elbows, or we're thinking of German shepherds with hips. We kind of have these ones we think about, but all of these can come into play. So if we have a predisposed breed that has a high impact occupation that causes trauma, and they're overweight, well, that animal is going to have osteoarthritis, unfortunately, develop and progress much faster. And I do want to touch on young animals because, we often think, well, they're young, they'll probably grow out of it. Well, that's not really a thing. Unfortunately, most of these animals, if they are predisposed and we see changes early, they're usually not going to grow out of it because it's a congenital issue. Something was wrong from the get-go, and so they're just going to get bigger, and that problem's going to get bigger as well. So the earlier we know there's a problem, the earlier we can act. We want to look for this for chondrodysplastic breeds as puppies, those large breeds, and if we start seeing a problem, we want to start talking to that pet owner about, okay, I'm starting to see some problems here. We're going to have to be careful about weight management. We're going to have to be careful about, allowing them to do activities that could be damaging. Okay, is there a surgery we can do to intervene with this early before it gets really out of hand? The earlier we can discuss that, we can prepare that pet owner, and hopefully do our best to keep that pet from progressing as quickly. And then keep in mind, after spay or castration, we can see increased weight gain for 2 years due to metabolic changes because their hormones are now out of balance or out of whack there. So we can see that even with feeding a normal amount, we can still see that weight gain, and that can be problematic over time. So really, one of the big things, we want to manage that caloric intake for young animals. There's been a few studies now looking at labs when they have a dog that ate as much as they wanted, and then a dog that ate what would be considered a lower amount. I think it was about 75% of what the ad libitum dog ate, and those that were on the skinny dogs, they had much lower incidence of osteoarthritis. It developed later. They lived, I believe, about 2.5 years longer and had a lot less problems because they weren't as big. So that's something that we can really concentrate on early, keep these animals at a good weight, and it's going to set them up much better down the road. Won't spend much time on clinical presentation because, again, these are things that we often think of. Changes in habits, activity, performance, quality of life. These will be things that hopefully the owner brings up to us, but it's something that we, again, want to start asking with these patients, especially if we notice, we've got a middle-aged lab. Okay, are you noticing problems? Are you noticing changes? Slower to get up, slower to get down. When they sit down, they sit a little funny or they just plop down. Things like that are what we want to look for. Changes in appetite because some dogs, instead of going and grazing from time to time, now they go and eat all at once because it's sore for them to get up and walk across the house and get that food. And then pain, again, that's one where it can be some time before that pain is noticed. But if the owner is seeing that they're painful or limping or holding up a leg, then that can definitely show us that, okay, something's going on there. But we need the owner's input, and there's no right or wrong answers from the pet owner. We really, okay, if they say this is weird, we don't want to completely discount it because, oh, I've heard that before. But hey, for that dog, that might be new, and that might mean that, okay, we're seeing some early changes. We want to listen to that, and we want to kind of make note of that and see if we could figure out a way that might fit with osteoarthritis, and then thank the owner for that. And again, it might be that, oh yeah, that's normal, but don't just totally discount everything that they throw at us. Our diagnosis is pretty straightforward. Clinical history, there are client questionnaires that you can do. There's like the load, there's coast, there's a feline pain evaluation form as well. There's a lot of things out there that we can do as client questionnaires to kind of get them thinking about it. And then depending on what that score is, it can say, yes, this animal likely has early osteoarthritis, or maybe not early, they have osteoarthritis. So that can help us out. And then even videos, having the pet owner record the video at home or record the pet at home, bringing it on their phone or email it ahead of time so you can look at it beforehand is always nice because you can see them walking at home. You can see them walking in their normal environment, which when they're in the clinic, we know that at the clinic they're stressed, they're not showing pain, they're looking around, they're hearing all these noises, all these sounds, so they're not thinking about it while they're in the clinic. But when they're at home and relaxed, that's when we can see those activities. And with our clinical signs, when we do our physical exam, watching that patient walking around the room, are they favoring a leg? Are they holding up a leg? When they're walking, is their head going up and down? Keeping a watch on that. The things that we want to keep in mind is that osteoarthritis, usually they're not crying out in pain because it's been a slower onset. It's been going on for some time. It's not a sudden injury necessarily, so they're often kind of used to it. And often with arthritis, we don't have non-weight bearing lameness. They might be, holding that leg up, they'd be putting less weight on it, but they're not, granted, if it's like a ruptured cruciate, okay, that's soft tissue. Years down, months or years down the road, that's arthritis. But at that initial moment, usually we don't have that, that's when it's weight bearing lame, but that's not OA yet. And then ataxia, some weakness is one thing, but if they're truly ataxic, then that might be a neurologic issue. We might have some CP deficits. We might have something more going on. It may not be OA. It may be, something along the spine. There might be some muscle issues there. So those are things that we want to keep in mind if we're seeing those. Okay, I'm not going to say osteoarthritis is not in that dog, but it may not be causing that initial or that specific symptom. We're usually going to look at radiographs to get an idea of what's going on there, but we know that radiographs lag behind what is truly going on in real life and do not always correlate what is going on in real life. The joint fluid analysis is something that we might do if we're worried about a septic arthritis or maybe one of those weird, inflammatory or immune-mediated diseases. But we don't necessarily want to judge OA based on the radiographs. We want to judge it on the clinical signs, because especially the joint that you're looking at, because the hip, I mean, we've seen those dogs where there's basically no hip joint remaining, and that dog walks around pretty good because that hip moves at, kind of mid-range, and they don't have to necessarily extend. But once you do extend it forward or flex, move it all the way back, they yell, they cry out. But when you think about the elbow, there can be very mild changes, and that can be super painful because they're walking with it pretty well extended. And so they're often at that kind of threshold of movement. And so that's when we get that pain. So the x-rays on an elbow may look great or not bad at all, but that animal is really painful. We don't want to discount that based on the radiographs. In our clinical exam, one of the things that we'll look at, CREPI is, Dr. Torres at the University of Missouri talks about this, and I think a lot of, it's pretty common in most of the universities, but we think about CREPI. So crepitus, decreased range of motion, we're looking for effusion, looking for pain, looking for instability of that joint. And when you have clients in the room again, and you're doing these exams in front of your pet owners again, talk about it as you're doing it. What are you looking for? What are you trying to feel? What are you noticing? Explaining what you're looking for as you do it, one, helps them understand as you go. Make sure you don't forget something, because if you're doing that full exam, you're looking at that old dog. But then it also gives them a value. It's like, okay, he didn't just touch my dog and give him a massage. No, they were doing diagnostics. She was feeling the knee and told me, yeah, it's swollen here, and you can see how it doesn't move as much. And we don't have the flexion. And then, oh, look, I get this cranial drawer. Showing the pet owner that can definitely help them understand, wow, there is more going on. I didn't notice it, and hopefully help them be an advocate for you as well. And then again, I'm going to throw the cats in here. Don't overlook cats. They're not small dogs. Common sites that we have spinal or OA in cats would actually be along the spinal cord, often bilateral in the elbows. I mean, we can see it in the knees, we can see it in the hips, we can see it in the shoulders. But when you think about cats, it's often difficult to notice, or the pet owners may not notice it, because cats have a natural flexibility and agility that's higher than dogs. So they're, them jumping and doing some of those things, they can still do it. But they also have that predator-prey instinct. And so if I show pain or if I show weakness, I could be eaten. Even though I'm trying to chase that mouse, I'm worried about the dog behind me. But with cats, one of the things that owners, they sleep all the time anyway. Well, I don't notice much, but Fluffy isn't sleeping on the bed anymore, or not jumping on the couch, or not jumping on the kitchen counter like they used to. Or now when they jump down, instead of jumping out and away, now they're kind of sliding their forearm, front end down and just lowering them down before they actually hit the ground. That's reducing that impact when they hit. So, I mean, that's one of the things we noticed with one of our cats. She was hesitant to jump on the couch, hesitant to jump on the bed. And so we're like, oh, well, 11 years old, 12 years old, that's not too surprising. But, and then she wasn't jumping on the kitchen counter, which was good, but we'll get into that in just a minute. One thing to note is that 40% of cats with osteoarthritis have pain, and they're often not being treated for it. So it is something that not only is it underdiagnosed, but they're painful, and they're just doing a really good job of not showing it. So even a pet owner that's like, yeah, they're not getting around as well, they may not notice signs of pain in the cat because we're dealing with cats. So there's painfreecats.org. Dr. Lassell over at NC State, they have a lot of good resources there. They have videos, they have little charts, things that you can show your pet owners to help them understand what could mean that a cat has osteoarthritis. Okay, now that we got that out of the way, now we'll get into some of the therapy. And it's really, some of the principles that we have of this is that, again, this is a progressive degenerative disease. So we're typically not going to cure the disease. So what we want to try to do, we want to preserve that joint mobility and normal range of motion. A lot of ways we can do that. We want to control that joint pain and inflammation, because the more pain we have, the less active they're going to be. The less active they are, the more weight they're going to gain. The more weight they gain puts more stress on those joints, which makes them more painful, and we get that vicious circle there. So every bit we can do to manage that pain, manage that inflammation, is going to make that patient much more comfortable. So hopefully we can keep preserve that joint mobility and range of motion. Then we do want to prevent further degeneration. We want to preserve that cartilage health as best we can, but each patient is going to be different. So it's not going to be every chocolate lab gets treated the same. It's not going to be, hey, this family has had German Shepherds. I've seen 6 German Shepherds in this family. Well, this German Shepherd may not be the same as that last German Shepherd. And so we don't want to, kind of say, okay, we're going to treat them all the same. We need to think about it differently for each patient. And from one day to the next, or maybe not day to day, but maybe 1 year, okay, we've got more of an issue in the back end and we've gotten that worked out. But because they were putting more weight forward for quite some time, now we're developing issues in the forelimbs. And so now it's, we can have that dynamic where we're good here, now we've got a problem here and making that better. And so we, keep in mind that things will change. And similar to cats, 50% of dogs with OA are actually being treated. We might be underdiagnosing it, we're definitely undertreating it. And so that's something to keep in mind and help the pet owners understand, is that we do have options to help keep them or reduce that pain, reduce that inflammation, and it'll be very helpful for them moving forward. So as the title kind of talked about, we want to do a multimodal approach. And there's so many options and so many things that were available to do in veterinary medicine now that it used to be, we only had a few things to choose from. It's like, okay, well, we could do surgery, stabilize that joint, but that joint, even after a TPLO, it's never going to be normal. It's going to be better. That stability is going to be better, but that joint is no longer normal, so it will develop osteoarthritis. And then you've cut through the joint, and so we've damaged that joint. There's going to be problems as a result of that. So it's good if we can address those things, but it's not going to necessarily solve the problem. NSAIDs, pharmaceuticals, we've used those for years and will continue to use those. Very helpful. Joint supplements, there's even more and more of those out there now. We have some of the old standbys, but there's new products out there as now. We'll go over those a little bit. And then physical therapy is something that is definitely growing in interest, not just an underwater treadmill. This does not equal physical therapy. There's so many other things that can be done. And it's really cool, the options that we have now. Really, the most impactful, though, are the lifestyle changes. So improving their nutrition and improving their exercise so we can get that weight down, keep that range of motion. So these really have the biggest impact, but also the hardest to do. And we'll go over each of these in a little bit more detail as we go. So we're going to start off with joint supplements, and there's a lot of them. This is not an exhaustive list of joint supplements by any means. These are just some of the common ones and some of the ones that we're seeing kind of some of the newer products that we see out now. And hopefully you're using multiple of these. And that's, again, how we'd like to do it. Obviously, that's dictated by those pet owners and the pet. But if we're able to do a lot of these in combination, most of them work slightly different. So that way we're working in different modalities to every bit we can do to reduce that inflammation, reduce that pain, keep that cartilage healthy is going to help that patient in the long run. So we're going to start out with UC2, which is undenatured type 2 collagen. And so this is actually a patented ingredient. And so if you see this logo, that is UC2. And how UC2 works is it's through a process called oral tolerance or oral tolerization. And so basically, by ingesting small amounts of an antigen, over time, it can change the immune response to that antigen. So in this case, it's UC2. And so it leads to a change in kind of the T cells a little bit. So in the Peyer's patches of the small intestine, so you ingest UC2, UC2 crosses in the Peyer's patches of the small intestine. So that's that lymphatic tissue, one of the most active lymphatic organs in the body. And so that UC2 is presented to naive T cells. So these are T cells that haven't figured out what they want to do with their life. They're just still trying to figure it out. And so by presenting this UC2 to these naive T cells, that then turns them into Treg or T regulatory cells. And these T regulatory cells now kind of change their tune on how they approach this type 2 collagen. And we'll go into that a little bit more here. So I guess one thing I'll point out is UC2, with the process that it's created, it actually keeps the trihelical structure of that type 2 collagen. And I mentioned earlier that type 2 collagen is part of that 20% of kind of the structural component of that cartilage. So it keeps that trihelical structure and it keeps these epitopes, which are kind of the antigenic stimulus. So it keeps everything intact. So now, sorry, let me go take back a step. So in quote unquote normal osteoarthritis, we have collagen that is released into the joint. It's not supposed to be there. The body sees that as a foreign object. So our inflammatory cells come in, they find that, they secrete pro-inflammatory cytokines, and we get this nasty inflammatory process, not just in the cartilage. It starts to affect the soft tissue structure surrounding it, can even start to affect the subchondral bone. So with UC2, once we've ingested that UC2, we start to get these T regulatory cells. And so those T regulatory cells enter circulation, enter lymphatic circulation, eventually get their way to that joint. And now these T regulatory cells that have been oral, gone through oral tolerization, now when they see that type 2 collagen that's released in that joint or exposed on that joint surface, now they're going to secrete anti-inflammatory cytokines. IL-10, IL-4, transforming growth factor really changes that environment. And so we're actually going to start to kind of block that pro-inflammatory state and turn it more to an anti-inflammatory state. So we'll talk about it instead of being that catabolic state, that destructive state, it's more in an anabolic state where the body can try to heal itself. So it's really cool how it works, and it allows the body to do the work for us. And there's actually been a lot of studies out on UC2, and last year there was a review done that actually was pretty well done. Kind of walked through everything with UC2. They reviewed 18 studies from multiple different species, and in all of these studies, all of them show that UC2 is beneficial, and there were no adverse events seen in any of these studies. And so UC2 is a pretty cool ingredient in how it can affect how the body manages itself with osteoarthritis. And that is available in our product Flexin Advanced with UC2. And so it does provide 40 milligrams of UC2, which gives us 10 milligrams of that undenatured collagen. And this is important because this is what the studies have been done using 40 milligrams total, which gives us 10 milligrams of the part that really does the work. There are some other products out there that don't have these levels, and they might still work, but this is what the studies have been done on. And so it is from chicken sternum. Again, it is a patented low temperature process that keeps that trihelical structure. It's in these soft chews. It is chicken flavored, derived from chicken sternum. So if we have an animal with a chicken sensitivity, we want to be aware of that. That said, my cat Martini, the one I talked about that was struggling to jump up and down on the couch in the bed, we've been giving her Flexin Advanced for almost 2.5, 3 years now. She has a chicken sensitivity, so she's on a rabbit and pea food. We've had her on this for quite some time, and it does not cause any increase in vomiting or diarrhea with her. We actually have a lot of clients around the country that their dog has chewed up the bag of food or the Flexin, ate 30 or even 60 chews and didn't have an allergy reaction. That said, with allergies, you never know. So I'm always cautious if we have an animal with a chicken allergy. And if there's a dog that looks at chicken and chews itself raw, yeah, let's not do that. But if it's something that pretty nice response there. So the great thing about it is it's 1 chew per pet per day. So because we're using the body we're letting the body do the work for us. So whether it's a cat, whether it's a dachshund, whether it's a Great Dane, it is 1 chew per pet per day. Makes it very easy for the pet owner, makes it easy for you, and it can be used at any stage of osteoarthritis. So next up we have, one of the mainstays of therapy would be omega fatty acids. These have been used for quite some time, more often with skin conditions and allergies. But when we go at higher levels, then we can actually get some anti-inflammatory effect because it changes kind of the inflammatory prostaglandin route. So it kind of tips us more to an anti-inflammatory state. So there's a lot of products out there. The biggest thing is, we do have to go with a higher amount. So 100 to 200 mg per kg per day, with the maximum being 300 mg per metabolic kilogram. That's very important. So usually we're going to start out kind of this lower end and slowly work our way up, because if we start out at the high end, we're usually not going to like what comes out the pet owner is not going to like what comes out the back end. So we'll just kind of work our way up there. A lot of products out there. The biggest thing is just kind of looking at the concentration. Because again, when we're having to use some of these higher levels, we want to make sure that we're getting it to them without having to like give them a bottle of everything at one time. There's definitely some good diets out there that have integrated this into the food, and it's amazing what that has done for some of these patients. Again, we just have to make sure we're using a high enough levels to try to get to that anti-inflammatory effect. Then polysulfated glycosaminoglycans. These have been around for quite some time. With Vetoquinol, has chondroprotectin activity, decreases some of the degradative enzymes. So again, we want to protect that cartilage as long as possible. We want to help slow that progression. And usually we get better results the earlier we start. So we want to try to get this on board before things get out of hand, because it's hard for the body doesn't necessarily regrow that cartilage. So the longer we want to, or it's hard for the body to do that, I should say that. So the longer we can keep it intact, the better shape we keep it in, the better that patient is going to be. And so we'll typically start out, with a more frequent injections, and then go to, monthly, twice monthly, kind of let the owner kind of dictate that. And then even I had some clients that I trusted, that I knew were able to do this, and they actually did these injections at home. You can do it in cats as well. That's off label. But it is something that, it's a good product if we are able to, if the clients are able to do it, willing to do it. And again, the better results we get are when we start earlier. Then we have hyaluronic acid. That's a major component of synovial fluid and articular cartilage. It provides some lubrication to that joint. There are several products out there. An injectable form is typically going to have better bioavailability than an oral form, just with how the nature of it. When it's taken by mouth, it doesn't do as good a job as when it's injectable. But it's something that, there's some products out there that can be useful in that regards. Glucosamine, that and chondroitin, which we'll talk about next, long-standing therapy when it comes to managing joint health. This tries to provide some of the building blocks for that cartilage. And these are products that, there's been some studies lately looking to see how efficacious they really are. And I do believe they are useful, especially earlier on in the course of disease, when we can try to, provide those building blocks as it's slowly getting worse. But when it's more progressed, I think it doesn't always do as good of a job. But a lot of the products now aren't just only glucosamine and chondroitin, they're combinations with the other ingredients. So it's often the other ingredients that are really doing the effect there. Again, I don't say not to give glucosamine and chondroitin. It's just the effects can, later on as disease progresses, we often don't see as dramatic as improvement as what we might see earlier on. So chondroitin, we talked about that earlier, that it helps kind of form that proteoglycan matrix. It can actually help kind of keep some resiliency of that water, or keeping that water in that cartilage, give it some resiliency. So again, been used for quite some time. Good product, but again, I think earlier on is usually better. And then as we get further along, it's usually the other ingredients in those combination products that are more helpful. And green lip mussel is a common source of chondroitin in some products. So the green lip mussel provides chondroitin, also a good source of omega-3 fatty acids and various antioxidants, and actually has some LOX5 inhibition. So it works on that lipooxygenase inflammatory pathway. So those products that have some perna canalicularis, that green lip mussel, kind of gives us that chondroitin in a slightly different manner that has some other nice properties to it as well. Then we look at MSM, or methylsulfonylmethane. It's basically used, it's a sulfur source that we often in plants or other animal tissues. It actually allows the cartilage to absorb and soak up water to give that really good cushion, and might have some anti-inflammatory effects, maybe some antioxidant activity, and provides a little bit of that structure as well. So this will be a product that you'll see added to a lot of an ingredient added to a lot of products. Then we have ASUs. So we have our avocado soybean unsaponifiables. It's been shown in humans and dogs to help with OA symptoms, has some anti-catabolic, anti-inflammatory effects, and can be helpful in OA. I will say, and some of the products that I'm talking about have a lot of studies to them, and some have not many studies to them, and some have virtually no studies. ASU, there's multiple studies showing that it's effective. And again, it's often in a combination form that often gives other ingredients to it as well. And so, with some of these products, you might have them on one product initially, but then you might add in another product that works in a different way over time. And again, we get that multimodal approach. Boswellia, or Indian frankincense, is definitely a kind of a trendy product or trendy ingredient now. It's been used for a long time in various forms of more traditional medicine, and it's thought to have some anti-inflammatory properties. Although one of the issues we run into is it has poor bioavailability in a lot of cases. So there's some improvement in human studies and in a dog study. It's just a matter of, it doesn't have a lot of science behind it, but it's been used for a long time. So it's kind of, I'll leave it at that because everyone has their own opinion on Eastern versus Western, traditional, and all those things. So another common ingredient is curcumin or spiced turmeric. It has some anti-catabolic properties, anti-inflammatory properties. There are some studies showing that it may be beneficial to management of OA in humans and companion animals. But when we look at the companion studies, there's been some mixed results. And so it's one of those where the exact dosing on it may not have been quite figured out, and how well does it work alone, may not be the greatest alone, but again, it's often in combination with other ingredients, so we get that multimodal improvement there. Then eggshell membrane it's kind of a newer type of ingredient as well. It's not fully understood how it works. There's a study showing that it suppressed our tumor necrosis factor, so it's going to try to help slow some of that degradation. There was a study that showed it had some improved mobility and flexibility. The issue is a lot of the studies out there were different ingredients and different types of eggshell membrane. So there, you have to kind of look at what ingredient is being used and what the study was, because I've looked at a lot of these and a lot of these different ingredients, and some of you are like, okay, I'm not really sure what was tested here. But again, there's some studies showing that it is beneficial. Again, it's often in combination with other ingredients, and so the whole multimodal approach is typically, that's what I promote for sure. And I obviously didn't cover everything. There's newer types of, there's like a glucosamine blue. There's different types of more concentrated fish oils. There's other things out there now. So there's a lot of options. Again, I'm just kind of concentrate on ones that have kind of been around longer, have a little bit more science behind them. But there's still a lot out there. We'll move into the controlled exercise and rehab, which I've gotten a good exposure to over the last couple of days. But weight management is key. If we can reduce weight and in that patient, it's going to cause great effects for them clinically, not just in their clinical signs, but also more objective studies. So 6% loss can see improved clinical signs at home, and 8% loss or more, we can have actually improved ground force plate analysis. So we can see that truly scientific improvement. But if we can exercise 60 minutes a day, we can see a 30% decrease in lameness in one study. But we want to be careful about how quickly they lose weight. And we obviously don't want to start out with 60 minutes a day. We want to work our way up to that. But caloric restriction is one of the most effective treatments to reduce OA signs. But the tough part here is the pet owner has to do this. It's very rare that this pug is going to be opening up that can of, or that dog food. It's very rare it's opening up the fridge and getting things or getting the chips out of the cabinet. So we have to be careful, help the owners understand that any weight loss is going to be beneficial for these patients. And that controlled exercise, what we really want to do is make sure that we're doing it in a way that's not a problem. So we want to limit trauma. We want to help maintain that range of motion. We want to maintain that muscle mass, but we're likely want to avoid those activities that may have caused that initial injury. So if we have a flyball dog that tore its cruciate, well, I mean, even after surgery and rehabilitation, they can still do well, but that dog is probably going to have some problems. And so do we want to talk with the pet owner? Do we do something else that might be able to give that dog a good quality of life without further injuring itself? Or again, it's just a matter of that extra effort, that extra force can be problematic for these patients. Some good examples of controlled exercise would be leash walking, 20 to 60 minutes a day. Again, 60 minutes is definitely going to give us better results. And so we'll start 10 to 15 minutes, or maybe it's 5 minutes. Maybe it's to the end of the block and back for a week, and then we go to the end of the block to the other end. We want to kind of slowly build up to that because we don't want to overdo it. Just like ourselves, we don't want to overdo it and then cause problems. So we want to gradually increase to that amount. If they're able to swim safely, that picture of the pug, probably don't want that pug swimming for 30 minutes a few times a week. That may not go well. But if we have animals that do have a swimming pool or a pond, if you have a facility like this that has underwater treadmills, then those are definitely good options. And there's a lot of rehabilitation options, not just underwater treadmill, not just walking, because even when you're walking, if you're walking up a hill, that's putting some more weight and stress on those rear limbs. So it helps strengthen those rear limbs. If you walk across a hill, then it puts more weight on the downhill limbs, and so it helps strengthen them. Then you walk back the other way. When you're coming down a hill, it's more stress on the front end, so it helps them work the front. So there's some ways, even with normal walking, figure eights kind of help work the spine and help work their limbs. So there's things we can do, not just laser therapy and all those. But when it comes to the rehabilitation in general, can increase speed of recovery from an injury or surgery, increase strength and endurance, reduce pain, but then it often has a positive psychological effect for both the pet and pet owner, because you can have some of these things done at home because there are very minimal complications if done properly. The fun part is this list might be longer than the list of supplements. And so there are so many different rehabilitation options out there, and simple things like controlled exercise all the way up to an underwater treadmill. I mean, there's hyperbaric oxygen chambers. I mean, there's a lot of things that can be done with animals now, but you don't have to start with rehabilitation. You don't have to do all of these. You can start out, baby steps, because you don't want to overwhelm yourself, your staff, and your pet owners. So kind of, if you want to start this program or a rehabilitation program, start with, figuring out how to do things in the clinic, cryotherapy and thermotherapy, exercises that pet owners can do. And then we add in other units as able. But again, when we add in more of these options, if the pet owners are willing and able, then that's going to help that animal quite a bit. And then obviously it helps the clinic as well. I will say that CCRP, the Certified Canine Rehabilitation Practitioner Program, that is actually a program that we provide support to, and it's the only university-based credential program for rehabilitation. So it's a great program, and actually, if it's something that your clinic is interested in, please reach out to your Vetoquinol representative, because we actually are able to provide a discount on those, and we're actually sponsors of the equine program as well. So if that's something you're interested in, please reach out to me or your sales rep. In pharmaceuticals, I'm going to kind of fly through this because we're running out of time. Again, it's about that multimodal approach, because that pain associated with OA is very complex. We'd have different types of pain relievers that work in different ways along that pain pathway. So we often can use them in combination to reduce that pain, and can just help based on what we're truly dealing with. And the IVAPM, the International Veterinary Association of, International Veterinary Associates of Pain Management. Man, it's amazing how you forget an acronym after a while. But they have great pain management resources. They have formularies. They have kind of pain management plans. So they great resource, and you don't necessarily have to be a member to get access to some of that. But if you are a member, you get access to more things. And we know there's a lot of options when it comes to pharmaceuticals. NSAIDs are kind of a standard of care. We have Galliprant, which is kind of a newer form of an NSAID. Opioids, Amantadine, gabapentin, tramadol. There's a lot of things out there that can be useful. And NSAIDs are kind of the mainstays of therapy. We have a lot of options here. Each of them kind of have a different onset of or duration of effect. Usually going to be mild to moderate pain, acute or chronic. There's a lot of them on the market because one may work better for one patient than the next, or one patient might do better on carprofen, and then over time doesn't work as well, so we switch to daracoxib, or vice versa, or maybe they don't tolerate, maybe we have more side effects with one product than another. So it is, there's a lot out there, and they can be very useful. We just have to be careful about what we're combining them with. We can use them with some of these other products, but we don't want to use multiple NSAIDs. We do not want to use them with steroids, because that's when we're definitely run into problems with with more severe side effects. And when we're using NSAIDs, it's something that we don't always have to consider or to continue NSAIDs indefinitely. So we can always try a lower dose or less frequent dose. But when we think about like in early arthritis, maybe just a week or so to get them through a flare-up is enough that we need. Again, maybe modifying their weight, maybe doing some things to help strengthen their body. But as OA progresses, then we typically need a longer course of therapy. Then we have severe osteoarthritis. It's often needed daily. But if we can do some of this multimodal approach, maybe we can get to doing less. So instead of 100 milligrams of carprofen twice a day for 100-pound dog, maybe we're down to 75 twice a day, or maybe 50 twice a day. Those are things that we're often not able to stop it, but we're often able to reduce that amount. And one thing to keep in mind is like if NSAIDs help and that patient still isn't wanting to do it, then it's probably unwilling. But if it doesn't help, then that patient might be unable. So NSAIDs work pretty well and usually pretty consistently. So if we can reduce that pain, and they're like this dog pulling on the leash, they may not want to go on that walk. But if we're using NSAIDs and we've gotten that pain well controlled and they're still not able to do things, then they might be unable to walk. So maybe there's something more going on that we need to investigate further. Kind of move over to carprofen because one of the common products, carprofen's been around for quite some time, a lot of different products out there. Galliprant is a newer one, which works on the EP4 receptors. So we're actually looking at the prostaglandin E2. So we're a little further down on this inflammatory cascade because most of our NSAIDs work up here. So Galliprant works a little bit lower here. So it's going to hopefully, with a little bit more of a selective action, it can hopefully help reduce some of those side effects that we can see with other NSAIDs, although we definitely can still see them. So we want to be aware. But it's only indicated for osteoarthritis pain, not for acute pain, not for surgical pain. But it is another option out there that we have for these patients now. And opioids, these have been around for quite some time and very effective when used properly. The issue is that it's becoming harder to get in practice, more issues, more restrictions, and also, typically they don't always. Long-term use of these isn't always easy because they're usually, an injectable formulation. Some of the orals or transdermals might work a little bit, but again, they don't work as well. So it does limit our activity or our options to some extent, but they're very good for acute pain, very good for maybe some of these flare-ups, very good after surgery. Just makes it kind of tough for long-term care. Amantadine is another product that we can use that actually can help block that windup, that central sensitization that we can get where that repeated pain stimulus kind of just amps up the nerve roots in the spinal cord. So with using amantadine, that can sometimes help reduce that and might be often used with NSAIDs. So it might be one of those things that we can add into therapy to try to help reduce some of that pain for these longer standing ones, or if we're using it early on, hopefully we can even block that windup. So again, can be used about any time. Then gabapentin is another product that's been used a little bit more often now. Its exact mechanism is unclear, but it's thought that it changes some of I believe the calcium gated channels along those nerve roots. So it's trying to reduce that signal between nerves. So it often works well with neuropathic pain or chronic pain, again, typically used in combination with other products. But it does have, could be sedation or ataxia with some of these patients, especially at those higher amounts. So it's one of those things where it can be beneficial. We just have to have the pet owner watching out for some of the side effects. Then tramadol has analgesic properties, although it's been questioned a little bit recently as how effective it truly is. There have been some studies showing that it may not be as effective as we think. My thought, I used it when I was in practice and I thought it was helpful for some patients, not helpful for others. So if it helps, great. If it doesn't, well, maybe it's not for that patient. But this one is tough because it is now becoming more problematic because of its potential misuse on the human side. So we'll close up real quick. So this is actually a summary that Dr. Marcellin Little he's now at University of Davis, kind of came up with that I really liked and he gave us permission to use. So when we're looking at some of our options, weight management is very helpful, very safe, not the most convenient. Exercise can be very effective. it's safe when it's done properly, but have some potential issues there depending on what we're doing or what type of disease or process we're trying to manage. Again, not very convenient. NSAIDs can be very effective. The safety, that's always a concern, but very convenient. UC2, very effective, very safe, very convenient. And the other modalities kind of encompasses everything else. And so, there's some studies are better, or some have studies, some do not. The safety of most of these are pretty good when done properly, but the convenience, can be a little bit definitely differences between whatever we choose there. So with Vetoquinol, we do have our mobility program. So we do have our carprofen. We have Vetprofen, which is our carprofen product. We have our Flexidin Advanced. We have Triglyceride Omega, which is our triglyceride product. We have Flexidin Plus, which is our glucosamine chondroitin combination product. We help with our controlled exercise through CCRP training. And then we actually have client education through My Happy Pets, which is an online portal. And then actually, if you talk to your Vetoquinol rep, we actually do have these things called digital toolkits that actually provide you with pre-developed like social media posts, things to put on your website, little article types of things. So that's another thing that we try to provide. So that way we cover as much as we can to support you and your patients. Okay. Yeah, again, I'm sorry I could talk about that so much longer, but I think we sort of got in time, so we have a few minutes for some questions.
Yes, everybody, if you do have any questions, please type them in the Q&A area and I will ask them. But in the meantime, I do want to thank you, Dr. Lewis, for a lot of great information that you shared with us on OA today. And I want to thank our members for joining us on this kind of chilly April day, Tuesday afternoon. I give people just a second to go ahead and put their questions in the chat box.
And like I said, I did kind of breeze over this kind of fast and some of this, and so thank you for holding on for that. But there's a lot of other resources out there. Again, IVAPM, the ACVS, the surgery, they have some availability as well. NC State has quite a bit. A lot of the vet schools have more information on ways to help with pain management or some of the kind of the questionnaires. So there's a lot of resources out there. And again, it's something that more and more pet owners are aware of as these animals are living longer. Now we have those changes that just happen with age, which is good that we got them living long enough, but now we're dealing with these other issues.
Yes. We do not have any questions. You covered a lot of material, and I think you did a fabulous job. So I'm sure they're all well educated after attending today. So thanks again for your time, and thanks again to everyone who joined us online. Have a great day.
Thank you, everyone. Oh.